much for joining us today for another edition of the highlights of the American Society of Hematology meeting that was held in December 2021. My name is Amer Zeidan. I'm joined today by Dr. Nikolai Podoltsev and Dr. Rory Shallis, and we will be together presenting on myeloid malignancies. I will start by talking about MDS for around 15 minutes. Dr. Shallis will follow with highlights of AML for another 15 minutes, and then Dr. Podoltsev will finish with highlights of myeloproliferative neoplasms. Feel free to post your questions in the chat. And at the end, we are going to have 10 to 15 minutes. We'll try to finish around 12:50 so that you can ask your questions directly, or if you prefer, you can type them during the presentations so that we can also tackle them at the end. Thank you so much for joining, and I'm going to get started. So for MDS, basically, this has been a very exciting field. These are my disclosures. There has been a lot of new developments in MDS over the last couple of years, and I think this is an area where we continue to have new drugs approved. So one of the drugs that has been recently approved is a combination of oral decitabine with sidazoriden. So decitabine is a standard of care treatment for higher risk MDS that's given intravenously. The problem is that this drug cannot be given orally because it undergoes first pass effect in the liver and the gut, and therefore has not been able to do orally. Subsequently, sidazoriden, which inhibits the enzyme cytidine deaminase, as you can see in this slide, basically allows the decitabine to be given orally. And in a phase 3 trial called the Ascertain trial that we participated in at Yale, it was shown to have the same pharmacokinetics, which is the primary endpoint of the study, such as the intravenous decitabine. And based on this data, the drug was approved in the year 2020. The clinical results have been presented more than once, but the paper has not been published yet. So this is the presentation of the overall data from 2020, where the complete response rate was shown to be around 20%. And many patients achieved, as you can see, platelet and erythroid transfusion independence, around 50% of patients. And you can see the CR was durable around 14 months. The patients are still being followed for long-term survival. I think important update that was presented in this ASH in December was the activity in the lower risk MDS, because some patients had intermediate 1 IPSS, and as you can see, the complete response rate was also seen in those patients around 23%. So it seems that even for lower risk MDS, CDEC has activity, which is something we see also with the intravenous decitabine. However, it's not clear if this is the right dose for these patients, because we certainly see neutropenia and thrombocytopenia. And therefore, a phase 2 study, randomized phase 2 study was initiated where the CDEC is given in 2 doses, lower doses than the approved dose, in patients with lower risk MDS who are not responding to erythropoiesis-stimulating agents. So this study is open currently at the main campus for any lower risk MDS patient. Feel free to discuss any patients you might have for this study. Another drug that has been also approved in the year 2020 is luspatercept. So luspatercept basically is a transforming growth factor pathway inhibitor. So these transforming growth factor pathway proteins have been shown to interfere with erythropoiesis. And what does luspatercept do? It's a ligand trap, so it removes the inhibitory effect on erythropoiesis, and therefore stimulating red blood cell production. The drug has been shown to improve transfusion independence rates. You can see here the pivotal trial results from the Medalist trial, which was published in 2020. Yale participated in that, where around 1/3 of the patients achieved transfusion independence. So this was in the refractory setting after ESA failure. We currently have the COMMANDS trial, which is in the frontline setting. So this is open actually in several of the cancer center satellite centers, basically. This is available for frontline randomization against erythropoiesis-stimulating agents, and this is regardless whether the patient has ring sideroblasts or not. So please feel free to refer patients for this, or again, it's open in many of the care centers, so the patients can be treated on the trial right there. Hemitylostat is another drug first in class telomerase inhibitor that has shown also good data in the refractory relapse, lower risk MDS. You can see here the presentation from the phase 2 part of the Amer study, which showed a rate of transfusion independence of around 42%. So a good number of patients are achieving transfusion independence with this drug. So this trial has a phase 3 component called also the Amer, which has been open at Yale. The main part of the study has actually been fully accrued and closed, but there's an extension of this study. So currently, if you have patients who have lower risk MDS who are first line, they can be considered for the COMMANDS trial. If they have received ESAs and they are not responding, we have two options: the Amer trial with Hemitylostat, as well as the lower dose of the oral decitabine CDIC available for these patients. How about higher risk MDS? So many of you are aware of venetoclax having very good activity in AML. It's a standard approved drug now. It's an oral pill that's given for older patients with acute myeloid leukemia, and we've been using it for several years now. So there has been a lot of interest in exploring that in patients who have higher risk MDS as well with excess blast. And we have preclinical data suggesting synergy with azacitidine, because one of the common resistance mechanisms to azacitidine is actually upregulation of PCL2. Two trials were designed basically as early phase trials in the front line as well as in the relapse refractory setting after HMA failure, combining venetoclax with azacitidine. You can see in this slide the dose escalation design of that study that subsequently went to dose expansion. And this is in the frontline setting. Very important to know that venetoclax here was given for 14 days. So it's not continuously given like it is in AML, only 14 days. And the dose is 400 milligram, which is the same dose that we do in patients with AML. However, venetoclax has a lot of drug interactions, and it's important to adjust the dose accordingly and monitor the patients closely for infections, which are common because you get neutropenias. Those patients should be on prophylactic antibiotics and should be treated very aggressively if they have an infection. They need a lot of transfusion care as well, especially during the first 1 to 2 cycles. The patient should be seen at least twice a week and given transfusions as needed. With all of that being said, basically, we are seeing early activity with this combination. So the complete response rate is around 35%, which is similar to what was observed in AML. However, many of the other patients are achieving also marrow CR, where the blasts are less than 5%, and they are achieving hematologic improvement. You can see that the response is achieved relatively quickly. The first response is seen within 1 month, and those responses are durable, 12 months. You can see also that there's, and this is the main update that was presented in ASH 2021, you can see that many patients achieve molecular clearance where the TP53, for example, molecular load is decreased. However, the question in TP53 in particular is whether overall survival is improved or not. So I think this data is encouraging clearly. However, this is a single arm study. It's not a randomized study. Less than 70 patients were enrolled. And therefore, we have an ongoing registration study called the Verona, which is also open at Yale. This is a randomized phase 3 study in which patients are randomized in a double-blind, placebo-controlled fashion to receive either azacitidine with venetoclax or azacitidine with placebo. And we have presented the schema of the study in ASCO 2021. You can see here 500 patients will be enrolled. And this study continues to be open, and we encourage you to refer patients who have high risk MDS. I currently discourage people from using azacitidine and venetoclax off-label in the frontline setting because we still don't fully understand if it actually is better than azacitidine monotherapy. And that's, I think, another reason to consider enrolling patients on this study, which is open at Yale. In the refractory relapse setting, Yale has participated in a study that was led by the sponsor or organized by the sponsor. Similar design, dose escalation followed by dose expansion. And this was a smaller study than the frontline study. 44 patients were treated. Same dosing, 400 milligram of venetoclax given for 2 weeks. And venetoclax was added to azacitidine. So the patient had HMA failure, but the patient continued in the HMA. So it's azacitidine with venetoclax. And you can see here that response rate was seen in 39%. However, many of those were marrow CRs. The CR rate was 7%, but those responses were durable. As you can see, the duration was 9 months of the CR or the marrow CR. But most importantly, we are actually seeing, I think, clinically meaningful responses. You can see that the platelet and red blood cell transfusion independence among patients who were transfusion dependent at baseline. So the patient was needing blood or platelets. Around 1/3 of those patients are becoming transfusion independent by adding venetoclax to azacitidine. And you can see that many patients achieve hematologic improvement as well, 43%. And the median overall survival was 12 months. We know historically that median overall survival after HMA failure is around 6 months. So it does seem that we are seeing promising activity with this combination in the refractory relapse setting. I think another important study from this ASH meeting was the phase 3 update using pivonidistat. So pivonidistat is an NID8 activating enzyme inhibitor. It works upstream of the proteasome. So this is a negative phase 3 study. The reason why I think this is an important presentation is because there has been a lot of early data with pivonidistat. We had a randomized phase 2 study with pivonidistat that showed the CR rate was 50% more than double that of AZA monotherapy, and we had durable responses. So there was a lot of excitement about this drug, and we did participate in the phase 2 part of this evaluation, but not in the phase 3. However, you can see here in the phase 3 that there was no difference in the event-free survival, which was the primary endpoint, no difference in the overall survival, and even in the CR rate, there was no improvement with the combo. So that, I think, highlights why it's very important we enroll patients on phase 3 trials and not just assume activity based on phase 2 trials. How about immune checkpoint inhibition? As I'm sure you know, in solid tumors, immune checkpoint inhibition has led to very important progress in very difficult to treat tumors such as melanoma and lung cancer. Early data with immune checkpoint inhibitors in MDS has not been so far particularly great. This is an example of this study that was conducted at several centers, including Yale, where we showed that there was no difference by adding durvalumab, which is an approved PD-L1 inhibitor that already has very meaningful clinical activity in solid tumors, by adding it to azacitidine. However, there are novel, I think, immune checkpoint inhibitors that seem to early results seem to have promising clinical activity. One of them is Sabatolimab. So Sabatolimab works on a receptor called TIM3. So TIM3 basically is an inhibitory receptor that is not only expressed on the adaptive cells, such as the T cells, but also it's expressed in the innate immune cells, including the macrophages, but also importantly on the leukemia stem cells. So this is being presented as an immunomyeloid agent because it leads to activation of the T cells and the innate immune system, but also it directly inhibits a loop of self-renewal within the leukemia stem cells by interfering with a ligand called galactin-9 that binds to TIM3 on leukemia stem cells. So this drug was combined with azacitidine and decitabine in a phase 1 trial. You can see here the early data that was presented in more than one ASH meeting. And the CR rate was not very high compared to as a monotherapy. However, in certain subsets like TP53, for example, the CR rate, the CR was durable, and the median duration of response was 21 months, which, again, in a very difficult field such as CP53, I think is very exciting. But we are also seeing hints of durability in other subsets. So clearly, there is also excitement about this agent. There's actually a randomized phase 2 and a randomized phase 3 trial. Both of them were open at Yale and they are fully enrolled. And we have 2 other studies with this drug, one in combination with oral hypomethylating agents. So you can give the CDIC, the oral decitabine, with this drug, and another study of a triplet where azacitidine with venetoclax and sabatolimab will be given for patients with high risk MDS. And both of those studies will open at Yale. Lastly, the IDH inhibitors. This is dawn of the precision era in MDS, like other malignancies in leukemia where we do it more. So IDH approved clearly in MDS, but we have seen 2 presentations from the French group in ASH where we are seeing basically activity and responses with enasidenib for IDH2 mutated MDS and ivosidenib for IDH1 mutated MDS. So I think this is an option clearly off-label, but in the absence of a clinical trial, I do check for IDH mutations for patients with MDS and consider using these drugs. Lastly, CPX351 or liposomal daunorubicin was cytarabine approved for secondary AML is also being studied in high-risk MDS patients who have excess blast in particular. And we are seeing encouraging activity. Again, this is single-arm study, small number of patients. Those are not your typical MDS patients. Those are younger, fit patients who go to transplant. So this probably does not apply to most patients. And this is intensive chemo. So there is high risk of toxicity. Those patients should be monitored the same way you would consider someone who is getting 7+3. So in summary, a lot of active investigation for new agents in MDS. I think the field is clearly very exciting with looking like a therapeutic revolution similar to what's happening in AML. And I think to continue with that, we need to continue to refer patients for clinical trials. So thank you so much. This is my email. Many of you have my cell as well, and feel free to reach out for any questions about MDS or any other questions you might have. Thank you so much, and I will move to Dr. Shallis, who will talk about acute myeloid leukemia updates.
I have to confirm, is this presenter view or the standard view?
It's presenter view. Sorry, it's your view. You need to
switch it up. How's that look?
Good.
All right.
Yes,
thank you.
good.
So, all right. Thanks, Dr. Zeidan, and all of you for joining. I'll be reviewing some of the highlights from this past meeting as it relates to similar disease, acute myeloid leukemia, touching on a few that that caught our attention as a community. We can start with a retrospective analysis first. Liposomal daunorubicin, cytarabine, or CPX351, and hypomethylating agent, or HMA, plus VAN have shown survival advantage as frontline therapies for older and what we call adverse risk AML. Although HMA-VAN is approved for ineligible patients who are ineligible to receive intensive therapy, there's an increased use of this combo in older intensive therapy eligible patients, including adverse risk disease. Furthermore, there's no getting around the fact that CPX is just pretty darn expensive. And we also recently published data on this in relation to classical 7+3, but getting back to CPX and HMA-VAN, there have been no randomized trials. So the two treatments have not been appropriately compared. There have been a number of retrospective analyses comparing them, but as upfront therapy for newly diagnosed AML, but this would be the largest thus far. So this was a multi-center retrospective study from 4 centers, Northwestern, Moffitt, Cornell, and Sloan, I think Sloan, presented by Pinkel Desai, and included 211 patients that were treated with CPX351 and just over 220 that got HMA-VAN. You could see here in the overall population on the left, baseline characteristics. The median ages were different between groups as expected, more adverse risk disease in the HMA-VEN group, like I mentioned. There's also a trend towards being a more enriched for P53 mutated disease, but the CPX group was more likely to have received prior HMA, a relevant consideration, given these patients probably, progressed from MDS. The study team was also interested. On the right here, you can see in patients aged 60 to 75 years, which was the original age group studied for CPX 351 on the randomized phase 3, and differences between groups were about the same, as you can see here. With regards to outcomes, more patients achieved CR in the CPX group, but more CRI in the HMA-VEN group, as you would expect, given the cyclic continuous myelosuppression that's encountered with venetoclax specifically. However, these differences appear to offset when looking at the overall or composite CR/CRI rate. There was a trend towards better CR/CRI in the TP53 mutated subgroup, and interestingly, no differences in response rates for patients with prior HMA. Looking to the right, you can see that relapse-free survival, RFS, was longer in the CPX group, actually more than doubled, but did not meet statistical significance. However, median OS was better in the CPX arm at 17.3 months. Among patients aged 60 to 75 years, similar to the overall cohort, RFS was no different, but neither in this case was OS. In multivariable analysis, after adjusting for things like age, ELN risk, history of prior malignancy, and importantly, prior receipt of HMA, there was an advantage favoring CPX with regards to OS in the TP53 mutated cohort. However, it should be noted that among this population, age 60 to 75 years, just shy of 50% of patients in the CPX arm went to transplant, compared to just shy of 20 in the HMA-VEN group, so more than double. And this is important because transplant was a significant predictor of RFS and OS. They conducted another MVA in patients that were aged 60 to 75 years who did not receive a transplant, and found no difference in OS. So in conclusion, there was a significant difference favoring CPX in the overall cohort and in several subgroups, although no difference in CR/CRI. However, this is very likely related to a better rate of allotransplant in the CPX group, who likely had, as you'd imagine, fewer comorbidities, and thus, CPX could still be the standard for younger fit patients, even with adverse risk disease. Switching gears to some clinical trial updates, starting with targeted agents, given the dawn of a new era that Dr. Zeidan had appropriately mentioned, and specifically starting with frontline trials. We can talk about IDH1 mutated disease, which are found, so mutations in IDH1 somatic mutations are found in about 5 to 10% newly diagnosed patients. Ivosidenib is an oral IDH1 inhibitor that's FDA approved for two populations, specifically adults with relapsed refractory IDH1 mutated disease and those with newly diagnosed disease but are just older, 75 years plus, or of comorbidities that quote unquote preclude the use of intensive therapy. There are already data from a phase 1 study of, I think it was 24, 25 patients with newly diagnosed disease that showed a favorable safety profile and pretty encouraging clinical activity for the combination of ivosidenib plus azacitidine. And for that reason, and also for the fact that this trial started enrolling, I think I want to say March or April of 2018, before we had the VIALE-A data, this prompted a double-blind, randomized, placebo-controlled phase 3 study where patients were randomized 1-to-1 to receive AZA or AZA plus ivosidenib, with a primary endpoint, as you can see on the right here, of event-free survival, which was defined as time from randomization until treatment failure. 146 patients had been enrolled as of this data cutoff was March of 2021. And as shown here, these were older patients with a median age of 75 to 76 years, a third with an ECOG performance status of 2. Also, about a quarter of patients had ELN-defined poor risk disease. In looking at responses, which was not the primary endpoint, there was a statistically significant difference in CR, as well as composite CR/CRh favoring the AZA plus ivosidenib arm, which namely demonstrated a 53% rate of CR/CRh. And half of these patients experienced mutational clearance, which is increasingly is being recognized as a predictor of durability of response and improvement in event-based outcomes. In the intent to treat population, in line with the better rates of response and deep response by NGS MRD, there was a better EFS in the AZA plus ivosidenib arm. This also translated into better OS for that arm as well, quite striking at 24 months compared with 8 months, as you can see here, for patients just getting AZA alone. And this is generally what we expect for patients getting AZA monotherapy. Did it come at the cost of more toxicity? Not really in looking at hematologic tox, but perhaps a little more neutropenia, thrombocytopenia. Non-heme tox was also about the same, but the frequency of all-grade differentiation syndrome, a concern with ivosidenib among a couple other targeted agents, as assessed by investigators, was about 14% in the combo arm compared to 8%, I think 7 or 8% on the monotherapy arm. Although grade 3 differentiation syndrome was only about 4%, however, in both arms, so not terribly different. And looking on the right here, you can see these are patient-reported outcomes and measurements of quality of life. You can see that IVO plus AZA appear to be a bit more favorable. So, in some, there was an IDMC recommendation that further enrollment be prematurely discontinued, given the evidence of benefit for the combination. So I would say, how does this translate into clinical practice? Unsure as yet. It remains to be determined, for the patient with IDH-mutated disease, whether, he or she is best served with AZA plus ven or AZA plus ivosidenib. I'm personally unaware of any randomized trial at the moment, but suspect that is coming soon. Sticking with the same theme for frontline randomized trials, we should discuss the LACE-WING trial, which was just presented by Eunice Wang at the meeting. And this is a trial that randomized patients with newly diagnosed AML and who were inappropriate to receive intensive therapy to either get AZA or AZA plus gilteritinib, which is a FLT3 inhibitor that demonstrated efficacy and safety in patients with RIBS refractory FLT3-mutated disease, and what's known as the Admiral Trial. Similarly, this trial was launched before the results of the ALI-A were known. The primary endpoint of this trial was overall survival, so not EFS and not or more of a response-based endpoint. Patients were originally randomized 1:1:1 to either get gilteritinib monotherapy, gilt plus AZA, or AZA alone, but due to what was cited as being a preferred therapy change, it was modified to randomize patients 2:1 to get either gilt plus AZA or AZA alone. Baseline characteristics are shown here and demonstrate that this was, as expected, an older population with median age of 77 years, and also a good proportion with an ECOG performance status of 2+, with perhaps some imbalance in favor of the AZA monotherapy arm. As expected, there were about 80% ITD mutations and similar rates of ITD high disease without, at least for my eyes, clear imbalances. That's pretty much it for this slide. With regards to responses, CR rates, not the primary endpoint, which is OS, like I mentioned, were similar between arms, but the rates of CRI and CRP, which are less than CR responses, still felt to be clinically meaningful, were higher in the combination arm, nearly 3 times actually, for a composite CR rate of about 58% for the combo and the 26% for AZA monotherapy. However, it's pretty clear from this KM curve that overall survival was not different between arms at about 9 months. It should be noted, however, and this was discussed at the meeting, and I believe it, that this may be explained by a couple things. Subsequent AML therapy was received by 20% of patients on gilt AZA and just shy of half of patients on the AZA monotherapy arm. Median time to that next therapy was a bit longer in the AZA, the combination arm. It was like 8 versus 5 months. So this might have influenced OS in addition to the imbalance in performance status that I showed you earlier. On the right here, looking at unplanned subgroup analyses, improved overall survival with gilt AZA was really not observed in any, although some trends were noted for patients that were more fit, and also here with high ITD allelic ratio. I didn't show any adverse event data here because they were largely similar between arms, including grade 3+ events. So in sum, although a negative trial, still an informative one, supporting the contention that AZA-VEN, as based on the ALI-A, may be the preferred combination for older patients who are inappropriate to receive intensive therapy with FLT3-mutated disease at the moment. I guess that can always change. Last year, I had reviewed the data for AZA and magrolimab, which is an anti-CD47 antibody that blocks the, quote, "don't eat me" signal on macrophages, and specifically the pretty robust efficacy for patients that have both P50 mutated disease and wild type disease. Actually, for the mutated cohort, just over 12 months would be the longest median OS reported for that particular subgroup. But like everything else, this has to be combined with AZA-VEN, right? But I will say, there are a number of preclinical studies which do support synergy for this combination. So this led to the this trial, which was a phase 1b/2 trial to evaluate the triplet in patients with both newly diagnosed disease, but restricted to P53 mutated disease, as well as refractory disease, regardless of p53 status, the latter being the only cohort for the phase 1 portion. And the primary endpoint for this trial was a composite rate of CR/CRi. Here are some baseline characteristics to date. I should mention that, actually, skip that part. So basically nothing out of the ordinary, in line with what I mentioned as how the kind of cohorts were divided up. You could see that, the age is maybe a bit younger in the mutated cohorts and the RIPS refractory, specifically the Ven naive cohorts, as you would imagine. But other than that, no major surprises from a baseline characteristic standpoint. And looking, well, just to go over some safety data, no DLTs were observed in the phase 1b portion, and the RP2, the randomized phase 2 dose. A recommended phase 2 dose was established at 30 milligrams per kg, with about a 2-week kind of priming dose ramp up, and then eventually it gets a bit easier for the patient every 2 weeks, cycle 3 going forward. So getting to some efficacy data, notable findings. First, the rate of CR being based on 14 patients with TP53 mutated disease was 64%, double what you would expect with Aza-Ven alone. And this has been attributed to, at least at the meeting, a quick depth of response, with more than half being MRD negative by flow, and a first response in less than a month, without really any, as you can see here, any early mortality. And what I would consider to be a reasonable time to blood count recovery felt to be meaningful, and really aligning with the definition of what we call CRH. Frontline treatment for wild type patients was even more impressive, with a CR/CR rate of 90%. Conversely, and this is one of the downsides, this doesn't appear to be a meaningful option for patients who've already been failed by a venetoclax-based regimen, with the CR rate, as you can see here, based on 15 patients, but still 0, and only 20% rate of CRi. And at the bottom here, you can see 20%, I get small numbers, but 20% rate of early mortality. Here's a look at the swimmers plot that was presented at the meeting. Much of what the last slide kind of showed, but also including data demonstrating that there's 100% 6-month OS. So short follow-ups you can see here as well for patients that had mutated disease, and 5 of the 14 that were able to get to some form of response were able to get to transplant, so about 35%. Of course, again, short follow-up, so maybe more will get to transplant, and we'll get a better sense of the median OS and see how it stacks up to the 12 months noted for the Aza-Magro Delta data that I presented to you last year. Frequent, here's some more toxicity data, frequent AEs of all grades, hypokalemia, hypophosphatemia, hyperbilirubinemia, about half of patients, and some otherwise heme tox you would expect with Aza-Ven itself, not necessarily Magro attributable. Among 17 patients that were newly diagnosed and thus TP53 mutated, the median hemoglobin drop was just about 1 gram per deciliter. This is after the first dose, and even lesser after the second dose. So with close monitoring, this anemia was manageable, and the anemia, which just to give a refresher, there is some on-target hemolytic anemia, just that was a bit troublesome early on in the trial, but appears to be manageable with no SAEs, no interruptions or discontinuations due to this anemia specifically. So this is promising and positioned to possibly be a new standard. I mean, maybe a little ambitious, but for frontline treatment, both for TP53 mutated disease and even wild type disease, but of course need more data and more follow-up, and of course randomized trials to confirm this added benefit. They are underway. One last combination, and this one is one that's restricted to patients with relapsed refractory disease, and one that may have some promise for patients with molecular subgroups that of interest, and maybe patients who have been failed by venetoclax. To date, a critical area of need. After patients are failed by ven, it's essentially a black hole, black zone, whatever metaphor you want to use. This is another combination that adds to Aza-Ven, but for which there is sound clinical rationale. This is a therapy that targets CD123, which is the alpha subunit of the IL-3 receptor and is overexpressed on leukemic blasts, immunogen 632. It's a CD123 targeting ADC comprised of a high affinity anti-CD123 antibody coupled to a novel DNA alkylating payload. Good cell line data, good near and PDX modeling or experiments, good synergy between immunogen 632 and Aza and or Ven, including being able to quote unquote overcome Aza-Ven resistance. So for these reasons, this is a phase 1/2 trial of that product combined with Aza-Ven in patients with, as you'd have guessed, CD123 positive AML. To date, the triplet combo escalation consists of 5 cohorts, 4 with the investigational product dosed on day 7 of each cycle, and one cohort where it's dosed on the first day of each cycle, make it a bit more convenient for the patient. At the time of this analysis presented, obviously at the last meeting, 35 patients had been enrolled. Baseline characteristics are shown here, and median age was about 65, so it was somewhat younger population with median 2 lines of prior therapy, up to 3, so not relatively terribly pretreated, but half of patients did receive prior venetoclax, important to know. The tox profile was manageable in this inherently refractory population with multiple prior therapies. The common AEs were infusion-related reactions, about a third of patients, with only 2% being grade 3, and otherwise things you would expect with aza-ven alone. One patient in the day 1 cohort had to discontinue because of an infusion reaction that was considered DLT, but early mortality defined at the bottom here, 30 days, was 0%. So my last slide, among the 29 patients who were evaluable, efficacy was seen across kind of all cohorts, doses, and schedules. The response rate was 55%. And looking at the composite remission rate, it's about 30%, with maybe higher rates in the higher dosed cohorts. Of note, patients with prior ven had good anti-leukemic activity, as seen here on the right waterfall plot, and an overall response rate of 40%. Other subsets of note, filter-mutated disease, even more striking, albeit 9 patients, but 80% rate of composite remission. So in some encouraging in some molecular subsets in ven-treated patients, but certainly like the other studies I presented, more data to assure these values don't regress to the mean like unfortunately many other similar studies. That's my last slide. There are a few more presentations from ASH that I wish I could discuss, but alas, only 15 minutes, and I'm sure I'm over that already. So I apologize to Dr. Podoltsev and look forward to your questions at the end.
Can you unshare?
Sure can.
There we go. Still cannot share the screen. Right, here we go. Thank you. All right, so let me find my presentation here. Sorry about this technical difficulty. Here we go. All right, is my view okay?
Yes.
Okay,
Yep.
So these are my disclosures. So I'm going to move on to the outline. So I'm going to present 4 studies which I selected based on disease. I will talk about PVERA, myelofibrosis, CML, and one other condition which is infrequent, myeloid lymphoid neoplasm with eosinophilia, and FGFR1 rearrangement. So the first study I would like to talk about is the study which is look at rusfertide or PTG-300 and its control of hematocrit levels in patients with polycythemia vera. So the rationale for this study is, which is looking at hepcidin mimetic rusfertide, is the fact that in patients with polycythemia vera, iron is necessary to make red blood cells in the marrow, which is affected by JAK2 V617F positive MPN. So as you can see on the left, ferroportin is the main transporter of the iron from inside the macrophage to the circulation, and then delivered by transferrin to the bone marrow, which is utilized to make excessive amounts of red blood cells by JAK2 mutated red blood cell precursors. So the hepcidin, as well as rusfertide, which is hepcidin mimetic, will shut down the gates ferroportin and decreases the amount of iron which is available for transferrin to transport to the bone marrow. So it's kind of shutting down the door, but perhaps not the window. A little bit of iron is available, and the idea is that there is no iron deficiency state which is otherwise created by phlebotomies, by therapeutic phlebotomies, leading to decreased quality of life of these patients due to tissue iron deficiency. So this is a phase 2 trial of rusfertide in PV patients requiring phlebotomies. Patients with PV diagnosis based on 2016 WHO criteria were included. At least 3 phlebotomies in the last 6 months were necessary. Patients were treated with or without cytoreductive therapy. So the primary endpoint was proportion of patients in randomized withdrawal period whose hematocrit is maintained without the need for phlebotomy. The secondary endpoints is response of 29 weeks, absence of phlebotomy eligibility, and that's what I'm going to talk about today, as well as total symptom score for those patients who are receiving treatment with rusfertide. The idea is that symptoms will get better while they're receiving this treatment because iron deficiency state, which is otherwise present in patients treated with therapeutic phlebotomies, will be gone. So the study has 3 parts. The first one is dose findings part, 28 weeks. Then there is blinded withdrawal, and then open label part is part 3. So we're talking about 63 patients currently enrolled, enrollment between October 2019 and May 2021, and patients were treated up to 18 months, between 8 and 92 weeks. So you can see here that initial period is describing 6 months preceding the first dose of the drug, and patients are getting phlebotomized you can see this by red triangles. Right after first dose, there are very few red triangles. So this is before randomization. That's what we're looking for at first 28 weeks of treatment. 84% of patients did not require phlebotomy. 14% required 1, and only 2% required 2 phlebotomies. So very significant result, eliminating phlebotomies in almost all of the patients within the first 28 weeks of treatment. So this was actually true for both patients who received cytoreductive therapy and who didn't. On the left, 31 patients who didn't require cytoreductive therapy, and on the right, 32 patients who did. So from the standpoint of assessment of symptoms, MPN-SAF TSS scoring system was used weekly, and you can see on the left at baseline the score as well as the score after 28 weeks of therapy. So there is significant reduction of treatment of symptoms with this treatment, and specifically a third of patients reported at least 40% reduction of symptoms based on MPN-SAF TSS at 28 weeks. So the drug is effective at eliminating the need of phlebotomies. This is a subcutaneous injection, which patients self-inject once a week. So from the standpoint of adverse effects, to summarize, basically the main side effect was injection site reaction, which was seen in 28% of patients, and it was transient and did not require discontinuation of treatment. In summary, rusfertide, or PTG 300, is hepcidin mimetic, subcutaneously injected for PV patients, leading to elimination of therapeutic phlebotomy needs of majority of patients within the first 28 weeks of treatment. Also reversing iron deficiency, which was evident by increasing MCV, MHC, and ferritin in these patients. There was positive impact on PV-related symptoms, perhaps because of negating some of the iron deficiency related to therapeutic phlebotomies. It was safe and well tolerated without grade 3-4 adverse events. And we are planning to open phase 3 randomized control study at Yale for these patients. So the second study is for myelofibrosis patients, and it's on pelabresib monotherapy for patients with myelofibrosis. This is an update of ongoing study. I presented this study last year. So it utilizes this knowledge that bromodomain and extra-terminal domain proteins promote myelofibrosis. You can see the activation of NF-kappa B targeted genes leading to increased inflammatory response, aberrant erythroid differentiation, and aberrant megakaryocytic differentiation, manifestations of myelofibrosis. Inflammatory response causes systemic symptoms, as well as cytopenias, including anemia and thrombocytopenia, can be seen in myelofibrosis patients. So pelabresib is the subject of this study, also known as CPI-0610. It is a first-in-class selective oral small molecule inhibitor of BET proteins. It modifies the expression of genes involved in NF-kappa B signaling decreasing the cytokines, also promoting erythrocyte differentiation and normalizing megakaryocytic differentiation. So that's the background for the study. The study is currently ongoing. It's Manifest trial, global study, and it is phase 2 trial. So there are 3 arms, and the arm I'm going to focus on is arm 1. This patients who are receiving pelabresib in second line. So they were previously treated with ruxolitinib or were not able to take ruxolitinib for some reason. So the dosing is, it's an oral drug, so it's given 2 weeks on, 1 week off schedule. And there are 2 cohorts in this arm 1 part of the study. One of them is transfusion dependent cohort, 36 out of 60 patients accrued, and there is ongoing enrollment. And the second cohort, cohort 1B, finished enrollment, 50 patients. So the primary endpoint for transfusion dependent cohort is transfusion independence. For patients in cohort 1B, it's splenic volume response, 35% reduction of spleen volume. So the patients who were enrolled were either JAK2 ineligible, JAK2 intolerant, and the biggest group is JAK2 refractory resistant patients, 56%. This is a group of patients with poor outcomes. Median survival is about 14 months. So the SVR35 response at week 24 was a primary endpoint for group 1B, which is non-transfusion dependent cohort, and it was 18%. Most of the patients had some splenic response. 18% had reduction by 35%. So the symptom reduction by 50% at the end of the 24-week period was observed in 28% among all study participants, transfusion-dependent and non-transfusion-dependent participants. Finally, the group 1B primary endpoint, the transfusion dependence converting to transfusion independence occurred in 16% of patients. Overall, in the whole population, there was observed improvement in hemoglobin levels, as you can see on the right-hand side. And among transfusion-independent patients, 38% had improved hemoglobin level by 1.5 grams per deciliter at the end of the 24-week period. So there are some exploratory endpoints, including evolution of fibrosis in the marrow, and about a quarter of patients had improvement, including about 6.7% of patients who had improvement by 2 grades of myelofibrosis in the bone marrow. Improvement in fibrosis correlated with improvement in hemoglobin levels. So the side effects are summarized on this slide for the sake of time. 19% of patients reported adverse events which led to pelabresib discontinuation. Most of the side effects were grade 1 and 2. So in conclusion, this is Manifest Arm 1, looking at 64 patients, planned enrollment 110 patients. There was a decent reduction of the spleen volume among transfusion-independent patients, and there was an improvement in hemoglobin, including among patients who were transfusion-dependent, and 16% of them became transfusion-independent. Marrow fibrosis, and I didn't present this data, plasmacytokines decrease suggested potential disease modification by pelabresib. Majority of the most common treatment emergent adverse events were low grade, and we are planning to participate in Manifest 2 study, randomized phase 3 study, double-blinded between CPI 0610 and ruxolitinib versus placebo and ruxolitinib at Yale. So the next study is CML, and this is about asciminib, the drug which was recently approved for patients with CML as a third-line treatment. People who were enrolled in the study received at least 2 TKIs, and the presentation I'm focusing on today is update of what was previously presented. So this is the drug which inhibits BCR-ABL oncoprotein activity, specifically targeting ABL myristoyl pocket. It's a different way of inhibiting BCR-ABL. As you can see, even with T315I mutation, where ATP pocket is changed and regular TKIs cannot attach, asciminib is able to inhibit ABL1 kinase activity. The study is a phase 3 trial which randomizes patients between bosutinib 500 milligrams once a day and asciminib 40 milligrams twice a day. Once again, these are patients who were previously treated for chronic phase CML with at least 2 different TKIs. And the initial presentation at previous ASH meeting looked at primary endpoint, which is major molecular response at 24 weeks. This presentation updates the results by expanding observation period for additional 7.5 months. So basically 19.2 months from randomization period. So the key secondary endpoint is MMR rate at 96 weeks is not presented yet. So this is the first presentation in ASH 2020, which was also, the data was also published in Blood last year. So the asciminib was better than bosutinib from the standpoint of primary endpoint, which is major molecular response at 24 weeks by 12.2%. So the updated 48-week results continue to show the higher major molecular response rate. So basically at 1 year, it is 29.3%, which is 16% higher than with bosutinib. Also, reduction of BCR-ABL transcript to less than 1% in blood is seen more frequently in asciminib arm, 42% versus 19%, more than double. So the deep responses are also better in asciminib. As you can see, MR 4.5, 7.6 versus 1.3%, and MR 4, 10.8 versus 3.9% when compared to bosutinib. So overall, adverse events were less common in patients with asciminib than with bosutinib. So nevertheless, pretty much everyone had some kind of adverse event, but adverse events leading to discontinuation, again, less frequent in asciminib treated patients. So these are most common all-grade adverse events seen in more than 20% of patients. You can see that asciminib is better than bosutinib, other than in cytopenias, which are seen more frequently among patients who are treated with asciminib. But this was transient effect at the beginning of treatment, usually related to the disease itself rather than to the treatment. So adverse arterial occlusive events were comparable in both groups, but it is challenging to say what would happen to bosutinib patients because they were observed a lot less than asciminib patients. So in conclusion, this is the first controlled study comparing TKIs for resistant intolerant CML patients using first-in-class drug, which is specifically targeting ABL1 myristoyl pocket. Superior efficacy was demonstrated for asciminib against bosutinib, and more patients remained at treatment at the end of 48-week period. So it has favorable safety profile. Now this is the drug which is available as a standard of care option for our CML patients, particularly with resistance and intolerance to 2 TKIs or more. So finally, the pemigatinib for patients with MLME and rearrangement of GFR1. So just to map that this is one of the myeloid malignancies. We spoke about MPNs, Ph positive and negative so far, but this is the myeloid lymphoid neoplasm with the eosinophilia. Eosinophilia is a hallmark feature of this group of malignancies, myeloid malignancies. I'm going to focus on this particular one, which is, I mean, all of them are not very common, but nevertheless, it's an interesting disease, which is due to translocation of 8p11, leading to constitutive activation of FGFR1. There are 16 known partners. Chronic phase of this disease may present as MPN, MDS, or MDS-MPN. That's why it is important to check if patient has eosinophilia for this rearrangement. Usually treated with hydroxyurea TKIs, including non-selective ponatinib and midostaurin. 50% of patients are in blast phase after 12 months, and median overall survival, and unfortunately only 9 months without a stem cell transplant. Long-term remissions are possible with transplants. Blast phase may present as AML, TOB cell ALL, and mixed phenotype acute leukemia. Once again, important test to do to select these patients. And there is treatment with lineage-specific induction chemotherapy, perhaps with the TKI, with 1 year survival under 30%. Those who achieve CR with induction chemo have superior survival, obviously, and long-term remissions are reported with transplanted patients. So overall, this disease is rare and also not very good to have because of lack of specific treatments, as well as poor outcomes with available therapy, perhaps other than transplant, which is available for a limited number of patients. So pemigatinib is this drug which is currently approved by FDA, as well as in some other countries for patients with cholangiocarcinoma, previously treated and resected or locally advanced. with FGFR2 fusion and rearrangements. The drug inhibits FGFR1/3, and that led to its study in this Flight 203 trial. So this is a swimmer's plot showing ongoing responses for majority of patients with chronic phase. There are 18 of them, and then there is this is the 13 patients with blast phase. Unfortunately, less responses here. A lot of patients, especially in the black box, who died from this disease in the blast phase. Nevertheless, some were bridged to allogeneic stem cell transplant. So in conclusion, pemigatinib is the first therapy to demonstrate durable and high rates of CR and CCYR in this group of patients. Previously, these patients were treated with other treatments. Majority of them progressed, including intensive chemotherapy and hematopoietic stem cell transplant. Kaplan-Meier median duration of CR and overall response have not been reached in those treated with pemigatinib. Clinical and cytogenetic responses were less frequent and durable in blast phase, but nevertheless, some patients were able to bridge to allogeneic stem cell transplant. There were no surprises in safety profiles and of this treatment consistent with FGFR inhibition, and this may be a good option for long-term treatment for patients with MLNE with FGFR rearrangement ineligible for transplant or facilitate bridging to transplant. Thank you.
Thank you, Dr. Podoltsev. Thank you, Dr. Shallis. Great comprehensive presentations. And we are going to take a few questions from the audience, if any has. So please feel free if you want to type your question, or if you want to ask directly, you can unmute. I think Renee can unmute you and you can ask the question. I'm going to actually start with one question for Dr. Shallis while we are waiting. So Rory, treatment of AML historically, 7+3 or HMA, really not much aside from that. So can you walk us through your thinking of the different options for a patient that potentially could be seen in any of the care centers? A 74-year-old male who walks with a cane but otherwise in a good shape, who comes with acute myeloid leukemia, outpatient presentation, and the patient has a FLT3 mutation and an IDH2 mutation, which we can see certainly in some patients. So how do you walk through, the different treatment options as you consider what to do with this patient?
Well, I like to think my practice is fairly evidence-based with some rare exceptions. And, I'd say this is a double-edged sword. I mean, it's very fortunate that the field is moving very quickly with novel agents, novel combinations with a recent preference for randomized trials, but by the time a trial is launched, let alone completed, maybe the reference standard, the comparator arm is obsolete. So at the moment, a 74-year-old is, age isn't all. Age is more of an imperfect surrogate for other patient-specific factors like end organ reserve. And I'd say maybe I put a bit more emphasis on the disease biology. And, with 2 targetable mutations, and an intensive therapy appropriate or eligible candidate, I would probably say this is a patient that probably would be treated with an intensive backbone plus midostaurin. You didn't give me if it's ITD high or TKD, but I think we can all agree this is probably a patient best served with that triplet regimen. If the patient was not intensive therapy eligible in the clinic, eyes in the beholder, then it's dealer's choice. Aza-Ven is probably still appropriate, just based on the lay swing data, that Eunice Wang had presented. And until we have a randomized trial looking at sequencing IDH versus FLT3, I think the question is still unanswered, but it's hard to stray from what we know from the BLEA. I think Aza-Ven would still be the standard if the patient is deemed to not be intensive therapy appropriate. And maybe in the next couple of years, we might have a randomized trial that looks at that, and maybe Aza-Ven could be superior to even classical intensive therapy. But at the moment, that's the dichotomy, I would say.
Perfect. So clearly a lot of options for this patient. This patient could go with Aza-Ven. Potentially some patients can still do IDH2 monotherapy, could be ADS with IDH2 inhibitor, could be 7+3, could be 7+3 with midostaurin. You still could consider transplant or not. So clearly many different options, and clearly the best option is always a clinical trial, which we always encourage. So I'm pretty sure in the care centers these patients are seen all the time, and I encourage people, even if the patient does not want to come to the main campus or cannot travel, to call one of us and go through some of the potential options that we have. Nikolai, for myelofibrosis, things are also clearly changing. You showed us some of the clinical trials that are in progress, but currently for doctors in practice, one of the most common, I think, tough situations is patients with myelofibrosis who are on ruxolitinib and anemic. So the patient basically has controlled spleen. They are not having constitutional symptoms, but they are needing transfusions, and they are on ruxolitinib, let's say 20 milligram POPID. Now we have a drug approved, bacteritinib, we have fedratinib, and there's another drug in front of the FDA, momelotinib, and a bunch of other things, ESAs, androgens, and potentially HMAs. So how do you think about these different options as you approach a patient like this?
So from the standpoint of FDA-approved therapy, we have ruxolitinib and fedratinib now for a while, and ruxolitinib is obviously dominating the market since 2011. So I think fedratinib was approved for a similar group of patients from 2019 and usually considered as a second line for those patients who are not satisfied with ruxolitinib, where ruxolitinib is not working anymore with variable results. So what we have approval is pacritinib on the 1st of March was FDA approved for patients who have low platelet count, so-called cytopenic myelofibrosis. And perhaps this drug can be used not only for patients who have platelet count less than 50, but maybe between 50 and 100, because effective dose of ruxolitinib sometimes is not feasible for this group of patients. So none of these drugs address anemia. So momelotinib from Momentum study, which was just presented, the data was presented as a company release, so there's no publication about that at the end of January. So this drug is geared towards patients with anemia who are progressing after ruxolitinib. Now, this was a randomized study against danazol, which you argue may not be the best randomization strategy. So there is some improvement in patients who have anemia there, but the drug is for symptom control, not just for anemia fix. The patient you were talking about at the beginning, ruxolitinib-treated patient with anemia, there is a study called Independence Trial looking at luspatercept for this group of patients. We know that luspatercept is approved for MDS with ring sideroblasts, right? So, and perhaps some people can get it off-label to treat these patients, but I think it is a little premature. We have to see how these results are going to pan out.
So what would you do?
So, for patients who, first of all, don't give ruxolitinib to patients whose main problem is anemia, right? So because anemia becomes worse. Ruxolitinib is the drug to fix the symptoms. And some patients would be happy to take ruxolitinib because they have bad symptoms and receive transfusions, because their quality of life, even though transfusions may be a little bit more frequent, becomes better. So we can sometimes try to give erythropoietin, like darbepoetin, 150 weekly or 300 weekly to those patients in conjunction with ruxolitinib, even though it's contraintuitive because ruxolitinib is JAK STAT pathway inhibitor, and erythropoietin actually activates that pathway. But ruxolitinib is not there 24/7. So we allow some hematopoiesis in between. So by doing that, and some of the patients may have less transfusion requirement. So it's either supportive care with transfusions or trying to give darbepoetin to those patients who need ruxolitinib, or trying to decrease the ruxolitinib, which of course is may lead to reoccurrence of some of the symptoms and worsening of symptomatology in those patients. So no perfect solution to this group of patients at this time.
Would you consider adding danazol also, or?
So danazol would be one of the options if erythropoietin doesn't work, with overall response rate of about 20%, which may last up to 2 years. Again, monitoring of liver function tests, PSA in men, would be important for this group of patients. Yes, this is a second-line option for anemia management. Amer, can I ask you a question? So because we have to move to the tumor board, I just have this question. So if there's no clinical trial and your patient with MDS, high-risk MDS, didn't respond to HMA, would you try to do off-label addition of venetoclax 2 weeks on, 2 weeks off to this patient if you can get it covered by the insurance? No clinical trial available.
Yeah, so that's again like the dilemma we have with those patients, because we don't have anything that's FDA approved for those patients. So I would consider it. However, I would be very clear with the patient about the limitations of this being off-label, We don't have a lot of data. I do think it's quite a myelosuppressive regimen. So for some patients, you have to expect that they are going to need to come 3 times a week to the clinic, need frequent transfusions. They will need to be on prophylactic antibiotics. So I consider it more in the setting where I'm thinking about bridging the patient to a transplant. If the patient does not have a transplant option, I think about it, but not as strongly, except in situations where the patient is in relatively good shape. The problem is that many of those patients are very old and they have a lot of comorbidities, and therefore, supportive care could be also, I think, appropriate in some patients. We'll just take one last question because I see it from Dr. Niparitsi to Dr. Shallis about why do you think there was no overall survival advantage with AZA GILT compared to ivosidenib with GILT in the Agile trial?
I actually answered in the chat, but I guess in brief, I mean, there were some imbalances between the groups. If we're only talking about the, the Lay-Swing trial, which is the gilteritinib trial, more patients on the AZA monotherapy arm were able to proceed to subsequent therapy, which of course could influence, any OS, for that group as well. I think it was like 40 versus 20%. So it was almost double. And there was also about a 4-month difference in time to next therapy. So patients were already committed. So that could probably, explain some of it. There was also a striking imbalance in the performance status, which is more of a surrogate for frailty, which is, again, debated itself, but more patients on the AZA GILT arm were just higher performance status. ECOG-2 was, I want to say 30% of all patients.
So, I thought that second line treatment with GILT in those who were treated with AZA, so would be also the main reason why there was no, at the end, overall survival difference in this too. And they work, so it's just very difficult to show overall survival.
Yeah, so and I think with all of these trials, I think doing these post-mortem is, a good thinking exercise. But at the end of the day, all of these should be thought before the trial, and what we have is what we need to go with. So thank you so much again. If anybody has any additional questions, feel free to send us an email or call any of us. Thank you so much, and I think we have the tumor board.
Yep. Yes, tumor board, please.